My name is Dr. Kimberly Pasley. I am one of the co-moderators. Dr. Scher is my other co-moderator today. Today we are going to be talking about ADHD, executive functioning, CF, and we have quite a fun panel today. So there are our learning objectives of what we're going to focus on today, and this is the plan. So as you might notice, we have one change in our speaker. Dr. Dell is unable to join us today, so I'm jumping into the mix. So, all right, we have little housekeeping. We will do questions at the end, sort of do a panel questions at the very end. You can ask all of the speakers anything that has come up, and please feel free to use the app, or of course, you're welcome to stand in the aisles and use the microphone. If you are asking and not using the microphone, we'll try to repeat the questions if they're hard to hear so that everyone knows what the question was. All righty, so we're going to have Dr. Scher give us a little background to ground us of what we're going to talk about today.
All right. Well, thank you everybody for joining us today. I think it's a very exciting, evolving topic in the world of CF. And so just to ground us, and I think some of this will be repetitive for many of you, but just to remind you, right, that Attention Deficit Hyperactivity Disorder is a childhood onset neurodevelopmental disorder. And in general population, the prevalence is roughly from 1.5 to 7% in children. And it actually decreases a little bit with age in general population. The ratio of males to females is 3 to 4 to 1 in females. And it's characterized by symptoms of inattention, so people making careless mistakes, difficulty sustaining attention on tasks, trouble organizing activities, being forgetful, easily distracted, and or hyperactive symptoms, right? Fidgeting, difficulty waiting for a turn, interrupting. The onset is before age 12. And we also, when we're diagnosing ADHD, we're looking for symptoms across a variety of settings, right? Home, school, and work, not just in one setting. So there was a great, paper from the Mental Health Advisory Committee, right, that also kind of reviews the symptoms, right? And here's some, again, symptoms of inattention and hyperactivity and impulsivity. And people can have just inattention, just hyperactivity, and both. There have been reports, and also it seems, true in clinical practice, that ADHD does seem to be more frequent, more prevalent in people with CF. It does seem that it's approximately 2 to 3 times higher in people with CF. So there were some studies done, for example, a multi-site study that came out of Israel and Spain, where a little bit less than half of those patients were males. So 18% of people presented with ADHD, right? And you can see how different that is, right, from the general population. 16% in the younger group, and actually a little bit higher in the adult group. A small study in the US indicated the prevalence of 15%, and also a small study from Turkey indicated the prevalence of 22%. So these are small numbers, right? But they definitely, the percentages are higher than what we see in general population. It does not seem to be associated in this, again, small studies with FEV1 and BMI, but it does seem to impair adherence to treatments, which is not surprising. And I think often this is how these patients come to our attention in CF clinics, as well as, some of the health-related quality of life measures. Why is there such potentially increased comorbidity between CF and ADHD? We'll kind of go into that a little bit later as well, but there might be a shared genetic predisposition. It might be due to the CFTR being expressed in the neurons in the brain, and I'm going to talk about that later. The life stressors, right, and chronic inflammation, and we'll talk about that as well. But we do know, right, that when a person with a CF or their parents, right, and there's definitely genetic predisposition, is affected with ADHD, not only it affects, again, all areas of lives and relationships, right, and their functioning in the society and schoolwork, and might make people more impulsive to use drugs, right, but it definitely does seem to affect their CF care, right? They're more forgetful to take medications, to do treatments, to come to the follow-up appointments, right? So it makes the management much more harder. So let's talk about kind of ADHD, cognitive dysfunction in general, and sleep in the next 2 hours. So this is actually a quote from Brianna Redland, right, on the CF community post board. And so, for example, she wrote a beautiful post about her experience with CF, and this is what she shared. So I experienced many symptoms, but some of those that impacted me the most were the inability to focus and stay on task and poor organization, memory, and time management. For someone with CF, it's very important to maintain a routine and remember to do regular therapies. I have never been able to create a structured routine that I can stick to. And as silly as it may sound, I often would forget to do therapies because it's almost as though I would forget that I had CF. Definitely, right, I'm a psychiatrist embedded in our adult CF center at Stanford, and I do see, right, many people, right, who come through our program. And I definitely have inherited many patients who do have diagnosis of ADHD, and I have diagnosed it as well. And it does seem that diagnosis and treatment of ADHD can truly make a difference in terms of their adherence, in terms of them being able to stay in school, succeed, and other areas in life. But let's talk more about this. Okay. And now we'll have Dr. Lillian Kristen. Okay.
So I'm supposed to do that one.
Oh, I think maybe start.
So there we go.
Yeah. Yes.
Okay, we did it. So thank you so much for having me today. My name is Lily Kristen, and I'm the mental health coordinator and a clinical psychologist at the Medical University of South Carolina. And I work both with our pediatric and adult care teams. No, I'm going to learn this. There we go. No, it doesn't work. There we go. Spacebar doesn't work either. Oh, there we go. I'm going to try this then. Old school. There we go. Mouse. So I have some travel support for this conference. And an important disclosure is I am not a neuropsychologist. So this is from a psychologist perspective, distilling this literature. There we go. So I'm going to talk through today some of the pieces of ADHD that I think will be common elements between a lot of our talks today. So kind of highlighting how ADHD is different than some other conditions but may overlap with them. I'm going to cover some of the key neuropsychological challenges of ADHD at various ages and how this can really affect CF self-management. And really also trying to bring home some of the strategies that we can use within our clinics to support people with ADHD and CF. But also when patients don't meet criteria for ADHD and may have some of the subclinical features. I want to acknowledge too that this is a really big topic. So as similar to the plenary speaker just said, I'm going to be doing an overview, but not a deep dive. And there's a lot more to learn, and I think some really exciting areas for research in these areas going forwards. So as Dr. Scher pointed out, ADHD is a lifelong heterogeneous neurodevelopmental disorder. So this is, in most cases, the onset is diagnosed in childhood and persists into old age. And there are a range of trajectories, which I think is really important to acknowledge. So some people have persistent ADHD throughout their lives. Some people have what we call their remitters, so they may move into adulthood and no longer meet criteria. And other people have kind of sub-threshold symptoms throughout childhood, but then really when they have higher demands later on, those ADHD symptoms really are much more apparent. There are substantial comorbidities. Executive functioning challenges may be one of those, and it's important to note, I'll get into this in a little bit, but executive functioning deficits are not equitable. They're not, EF, executive functioning, and attention are not the same thing. They're not equitable, but it is a comorbidity of ADHD. ADHD itself is diagnosed via behavioral symptoms. So that set of symptoms that Dr. Scher showed, that's how we diagnose it. But again, subclinical symptoms, so a combination of some of those symptoms can really impact functioning too. Again, this is a really important area, and I think we are only scratching the surface with ADHD and executive functioning. In our CF populations, the prevalence rates are much higher than the general population. And I think as we're learning more about the different possible contributors to this, I think there's some very interesting areas of research to pursue. This is a lot on this slide, and I'm not going to go into every single piece of this, but I do want to acknowledge that it's really important to focus on differential diagnoses. So we want to make sure we're differentiating ADHD from other things that can cause attention problems and concentration problems or even hyperactivity. We want to make sure we're addressing sleep apnea, for instance, if it's occurring, or if there's serious environmental factors that are causing difficulty with focus. We want to make sure we're addressing these too and really considering them as to whether the things we're seeing behaviorally might be better explained by something else. We also want to think about associated features, so things that kind of hang with ADHD, and executive functioning is one of those, along with sleep concerns. And also we want to think about comorbidities. People with ADHD often meet criteria for other mental health diagnoses, for instance, but also other physical health conditions, such as obesity. I want to just put a quick plug out there. I find it very interesting in my discussions with patients in clinic. A lot of them come in and say, I have ADHD, and I saw on TikTok that. And I just want to acknowledge this because I think, I know we talk about Dr. Google, but I'm going to talk about Dr. TikTok because I think Dr. TikTok is sometimes a lot more convincing than Dr. Google because you have these people there sharing their stories, and it can be very gripping. And so we know in the U.S., social media, internet, all of this health information is very accessible. Most people get some form of health information from the internet. And I just want to highlight, there's been some research looking at this for ADHD specifically, and there's just like a lot of concerns. So one being that ads are out there for, really kind of encouraging folks to self-diagnose, bring this into their providers. There's a lot of misleading information. So one study looked at the top 100 TikTok videos on ADHD, and they classified 52% of them as misleading. So I wanted to acknowledge this because I always want us to take our patients' symptoms that they are describing to us very seriously and really kind of listen, not dismiss them, but also make sure that we're educated so we don't provide information, or we can correct information that comes from Dr. TikTok. So there are a lot of different factors affecting ADHD symptoms and the phenotype we see. Genetics are a huge part of this. And I think that this is really important to acknowledge in the pediatric space, especially where when we think about our child who may have ADHD and CF, chances are the parent may also have some of those characteristics. And so when we're doing our education, we have to take that into account. Environmental influences also really have been shown to influence early genetic expression of ADHD. So things like maternal substance use can have an impact. And there's a lot of other factors, some of which kids with CF may be dealing with, such as low birth weight or other types of things may influence ADHD expression. Now, within CF, we know that there's a higher prevalence, and there's a lot of other hypothesized factors here that are so interesting. I mean, anyone out there who's interested in this, please do research on these areas because I think it is just a fascinating area. There's, Dr. Scher is going to go into some of these a little bit more, but there are some theories about neuroimmune functioning, so having chronic inflammation and its effect on the brain. Pediatric malnutrition, we know kind of across the board and in CF, this can lead to early brain development. When our gas exchange, when we can't breathe adequately, we can have conditions that may affect our cognitive functioning. And CFTR is in the brain. We don't understand exactly how it's functioning yet, but that may be one real mechanism. I also want to acknowledge the ETI effects that are neurocognitive in nature and may present as ADHD as well. And there's also some really interesting data in the ADHD literature too about glucose and insulin regulation. When we are using our executive functioning skills, it relies on glucose in the brain and then in the bloodstream. And when that's dysregulated, that can cause some concerns for executive functioning. So there are just so many theories. There are just umpteen theories of ADHD. What I think is interesting and why I'm focusing on the executive functioning theory of ADHD is that it's one that has some more accessible testing. There's a lot more research that's been available. And when you're doing a neuropsychological evaluation for someone who has ADHD, this is kind of one of the main things you're going to be looking at is executive functioning, as opposed to something like a dopamine reward system. There's a lot more lab-based tests that are involved in testing for some of the other theories of ADHD. When we're thinking about deficits in the executive functioning domain, we're thinking about challenges with focusing and strategic flexibility. So not able to kind of direct attention in a way that's strategic. Also having challenges in monitoring and inhibiting behaviors. So not having that break that we would want to see if we're driving a vehicle. We can break our behavior. We want to see that for many risky behaviors especially. And then also lower planning abilities and lower working memory. Self-regulation systems and emotion regulation are very closely tied into executive functioning, as I'll get into. And so those are the two ones that I will be talking a little bit more about today. But I want to acknowledge the umpteenth other many amazing theories, some of which you can kind of see here illustrated. And especially, I think I am very interested in like the reward pathways of the brain and the dopamine hypotheses there. I'm not going to cover those today, but that's another really exciting area in the ADHD world. So when we think about attention, I just want to provide a definition here. We can think about it as almost like a flashlight. So we're putting a flashlight towards something to see something specific. Deficits in attention may have this bidirectional relationship with executive functioning skills, but they are not the same. And that's an important thing to acknowledge. Many people who meet criteria for ADHD do not have impaired executive functioning. And so that's something to kind of note within this discussion. Attention is either on or off. We're focusing on something or not. It can be visual attention or auditory attention. You all are doing a little bit of both today, listening to this presentation, unless you've got your eyes closed. And all attentional skills have executive functioning elements. We think about with attention, we sometimes are thinking about focused or selective attention or concentration. So when, we may be having our phones going off, text messaging coming in. I turned my phone on silent before this because I know my kids back on the East Coast are having dinner time and they like to call and send messages. And so I was like, well, I am going to need to selectively attend to this presentation. So I'm going to put my phone on silent. Otherwise, I would have been definitely distracted. Vigilance and sustained attention, so our ability to focus over time. Anyone who's ever gone to a graduate training program has got some very good experience with this type of thing. So really kind of focusing on learning things in a very in-depth way and focusing in deep on that. And sometimes we do see people, this is divided attention is a skill that's a little bit more of an advanced skill, but being able to focus on two things at once or more than one thing at once. And we also think about alternative attention. So being able to switch focus from one task to another with skill. So being able to actually attend to each one well. So this is a picture of Roderick Cox. He is I think he's 31. He's a young, I think one of the first Black orchestra conductors in the country. Very cool stuff. And I picked this picture of him because you see him here. He is directing this very diverse orchestra. And the conductor, sometimes if we just look at them, they're kind of waving their hands. Well, what are they doing? Well, they're literally coordinating this entire orchestra to implement this beautiful music that we listen to. And to make the music work, every piece of those instruments needs to be working together. If they don't, you are not happy with what you're listening to. It sounds bad. And so the conductor is there to kind of organize everybody into working together. So our Roderick is what you can kind of think of as our executive functioning for the brain. And selective self-regulation, I just want to kind of draw attention to this here. Self-regulation is his ability to organize, to lead lead the orchestra, to get things done, to get this amazing task done. I don't know what piece of music he's conducting here, but it's an in-depth one. There's a brass section in the back. There's all these different instruments, and these are various. This is kind of how our executive functioning of the brain works. Executive functioning deficits are correlates of ADHD and can be present in people with CF without ADHD. So I just want to make that point again. I think what's really interesting is also thinking about making sure that Roderick can do this amazing task. To do executive functioning tasks, our brain is a metabolic organ. It uses glucose to function and really to do every part of its functioning. But the most taxing function for our brains that uses up the most glucose, both in the blood and the glycogen stored in the brain, is these executive functions. So Roderick, I don't know if this analogy works, but we might want him to drink like a sugary drink before he does this. In this analogy, we want him to have a lot of glucose in this brain analogy to be able to implement this amazing piece of music. This is a really lovely model. Adrian Borshuk published this a few years ago, and as part of a study looking at executive functioning in youth with CF, so not ADHD, to be clear. And I think it does a nice job of highlighting how executive functioning, both the skills within executive functioning that are present, but also how we can kind of think about this playing into a world of living with CF and ADHD and or executive functioning challenges. So executive functions are affected by some of these fixed factors, things that, we see some of the hypotheses there, these CF mechanisms there, along with genetics. And they also are impacted by some dynamic factors. And these dynamic factors are the things we may have some degree of control over. I think, one of the things that most people here may be able to, especially those from the East Coast, might be able to empathize with is sleep. So if you had a 8 a.m. or 7 a.m. talk the first day after you got here and you were trying to adjust to the time change, it's a heck of a lot harder to give a presentation when you haven't rested well, or maybe are adjusting to a different time zone. These dynamic factors are really important. And I think, these are things I like to think of as either filling our tank, our executive functioning tank, or depleting it. So I think, some of the things like stress, for instance, can deplete some of our glucose stores. It can affect our executive functioning. And the dynamic factors are things that we really have some ability to kind of control and adjust to some degree. All of these things really play back towards adherence or self-management behaviors. And, I think this model does a really nice job of highlighting this. And then, kind of the takeaway I want you guys to think about here is, how can we fill this executive functioning tank when it does become depleted, especially in the clinic setting? So the skills to plan and organize complete treatments, they are absolutely impacted by ADHD symptoms and executive functioning. It's a very understudied area, but everything is more effortful for folks when there are also these deficits in executive functioning or self-regulation. Our executive functioning tank gets drained more quickly. And this is it's called the ADHD life transition model. And this, we have to think about not only how the individual factors are playing a role, but also what supports are present. Across the life course here, you see this resource demand imbalance illustrated. And so in the early years, over there, we see period of life on our x-axis there. In the early years, we have not a ton of functional demands. It's pretty nice to be a kid. Not a lot you're being asked to do on the early years, or parents are helping you a lot. You got a lot of support resources. And that really progresses, especially in CF, when kids are starting to do more treatments, are starting to have to take more medicines. And this star here illustrates that transition from adolescence to young adulthood. All of a sudden, those functional demands go sky high, and the support kind of, for many people, it is not present as nearly to the degree that it was previously. And that can really impact how folks these symptoms kind of exhibit. So I want to turn my talk here now to thinking a little bit about what we know in the context of CF and how CF teams can help. All ages, we can be involved. We can screen folks. We can send them towards resources. I want to make the point that neuropsychological testing is super helpful, but it's not necessary for a diagnosis. Any trained provider can be able to make that diagnosis. We have a lot of great screening tools to aid in that. This is absolutely something that can be accomplished in the CF clinic, and maybe an important thing to start including as part of annual mental health screening, given the significantly high rates we see. We can also really help provide support around treatment planning, so really considering interventions in the overall health and wellness of the individual. This is not an intervention talk, but I do want to acknowledge the many treatments for ADHD. That's going to be something that the other talks are going to get into a little bit more. And I really want to highlight here that physical activity piece. That is something that we can make a huge impact on in clinic. There's a great meta-analysis that came out recently, Lambez, and this physical activity was shown to have the highest average effect size of non-medication interventions for cognitive symptoms for folks with ADHD, above and beyond CBT, above and beyond neurofeedback and these other interventions. So just want to give a shout out to physical activity. Thinking about our early years, what do we know? It's too early to diagnose ADHD, but we know that there's an increased risk for neuropsychological differences from an early age in CF. Early malnutrition has been shown to be associated with worse cognitive functioning later. And CF infants with pancreatic insufficiency have what are called increased auditory evoked potentials. They put an EEG on these babies and kind of look at their sensory processing. And I think this is fascinating. But these babies have these increased responses, which indicates that in response to some standard stimuli, babies with CF have more difficulties inhibiting processing of non-pertinent stimuli from being infants. So thinking about filtering out information, they have a harder time from that from the beginning. There's so much here in terms of what to know about ADHD. This is preschool and school age years are really when we start to see these symptoms intensifying. We see more trouble with inhibiting responses. It's hard to kind of suppress interference from these when we have conflicting pieces of information. There's more externalizing symptoms, and kids perform worse on a lot of different executive functioning tasks. For school-age children, we start to notice, especially in the context with harder things in school, more inattentive symptoms becoming present, and there are also a lot of executive functioning challenges. We could do a whole talk just on the nuances of those, but we don't have time for that today. And we do notice in a few studies that in CF, ADHD symptoms are associated with disease severity, but those are not have not been replicated. There's not a lot of data there. But we do know that youth with CF in general have lower visual motor reaction times and poorer balance and poorer performance on tests of attention and memory than controls. So how can we help? Early nutrition. This is something we do already, but I want to acknowledge the contribution of our registered dietitians to the brain health of our every age of people with CF, because that early brain health via really solid early nutrition is critical. We can also really encourage early identification and diagnosis. This is a chronic condition, and the earlier we get it diagnosed, the earlier we can treat it. I think sometimes there's a lot of hesitancy about initiating certain types of interventions, especially stimulant medications. And so I just want to acknowledge that this is something that we can really play a role in. And, whether it's being provided by the team or a pediatrician or a psychiatrist, kind of working with that provider to make it work, because the medicines do make a big difference. And we play a role from, every interaction we have with these kids in terms of early social skills development. Social skills are impacted in ADHD and when we have executive functioning deficits. And we play such a big role in how we really foster early communication and parent-child relationships. A couple of concrete things I want to point out. So we can really partner with families to develop some systems to help kids partner in their care. You'll see over here a physical representation of going to the doctor. So like helping them organize, knowing what to expect. Physical representations really help. We can also do what's called prosthetic motivation. So, and I use that term for a reason, not rewards, because kids sometimes don't have that element of natural reinforcement from some of these tasks. And quite frankly, much of what we're asking them to do is not fun. So there's not like a natural reinforcing aspect to it. So prosthetic motivation, Barkley talks about this as really giving a reward as a prosthesis for motivation, just as we would allow someone who has an amputation to use a prosthesis, and not to take that prosthesis away when that person has learned to walk. Oh my goodness, that's what we do a lot of times with rewards. You learn this, take away the reward. No, not in ADHD. We want to kind of continue those rewards. And also intervening at the point of performance. I think if you're doing a new skill, if you're teaching a family, a patient a new skill, do it in clinic. Don't just talk about it. I also want to point out, this is a really important point, but temporary depletions in our executive functioning take with stress or low levels of blood glucose when we ask kids to come in fasting make them very, very unable to learn new information. So if we're doing a really big education visit, it should not be the same day that they're doing their fasting labs. That doesn't make sense. It's for probably most folks, but also when it's in the case of ADHD. And we can think about ways to replenish that executive functioning tank in clinic. So providing snacks, giving breaks, giving some rewards when we're teaching new things. This could be a whole other talk all on its own, but I want to acknowledge ADHD and family members. You know, there's a lot of impacts of ADHD on how parents are able to implement treatments. It impacts ability to be adherent to medications when families are managing that. It also has a lot of implications for family cohesion and how families communicate. So sometimes helping get a parent treated for their ADHD will improve the trajectory of your child. And so there are a few things we can do. And I think the most important thing is asking and talking to parents about their concerns if they have them. Teens are complicated in every way, and especially in this area. I think with teens, one thing I just want to highlight is our prefrontal cortex, which is very much implicated in all of these executive functions. It is the last place to mature, which makes us very concerned about their risky behaviors and making good decisions, but also that's a good thing. We have a lot of time to really reinforce things, and repeated skills practice matters. And it's going to be more for someone with ADHD than the average person. It's not a one-time discussion, it's an every visit discussion. And that really matters for these kids. We do see some symptoms change in teenage years. So inattention does persist, but motor hyperactivity may decrease. But where we really see a big difference is both in some of the challenges, everywhere from academic attainment to risk of injury, but also some of the really serious comorbidities like conduct disorder and cigarette smoking are a lot more common in teenage years with ADHD. The other thing that's very different here is this: we're at the kind of cusp of this demand resource imbalance. The executive functioning tank is going to be draining quicker, and there's so many more demands for teens as they're learning how to take this all on their own. So again, we need to think about ways to provide them support. We can do that by actually reinforcing some of the systems that worked for them as kids and helping them transition it to doing it on their own. So thinking about how to self-manage some of those prosthetic rewards. I want to highlight sometimes having more visits just via telemedicine, or just more quick check-ins with the nurse coordinator, things like that to reinforce teaching information might be really helpful, because it isn't possible to have these kids with ADHD come in every week, every month. This is not going to be feasible, but telemedicine does open the door for some additional coaching. I think it's so important during these years to instill confidence and motivation for that self-management. A lot of times teens feel like we're just telling them that they're doing things wrong. And there are some wonderful strengths to highlight for folks with ADHD. There's a lot of creativity, and engaging some of that can be really helpful in adapting some of these care plans. And whether they should or not, they do view us as their primary providers a lot of times. So we're the ones who are going to be providing them with a lot of anticipatory guidance about high-risk behaviors, ranging from texting while driving to sexual behaviors. So for adults, I'm going to just breeze through this because I know Liz is going to cover this and I'm very much over time here. But there is a huge impact for adults with ADHD, and especially some interesting things to note within CF. One of the things I want to note too is the increased risk of obesity for adults with ADHD. And I think this is especially relevant in our ETI era, where we're seeing more and more concerns with this for folks with CF overall. This may be especially of concern for people with ADHD. Now, there has been some data to show recently that there are really significant cognitive dysfunctions for people with CF compared to controls, and kind of even more so when we look at CFRD, patients with CFRD compared to folks with CF and controls. And Dr. Scher is going to talk a bit more about that. With our adults with CF and ADHD, we can really help by kind of accepting a longer transition period and making the focus of teaching them these skills part of our goal. I know we talk about transition a lot with all patients, but these teens may need a lot more specifics and bringing some of the things into the clinic space, not just talking about, oh, how do you keep track of these things? But saying, show me what you're doing. Show me how you're managing this. Also talking about selecting careers. There's very much a difference in different types of careers and also schooling. Some provide more support, some provide less. And, based on the person, that's very individual. Some folks with ADHD do better with online schooling, and some do better within the classroom. So kind of tailoring that discussion to what their skills are. I want to give a shout out to all of our social workers and nurse coordinators too, because there's actually a pretty big challenge for many folks around getting adequate medication support and coverage. And this is something that they can really help us with as well. We want to provide additional support to our folks with CF and RD and ADHD because, as you'll hear, there especially some unique challenges in that case. And so, ironically, managing CFRD is also really hard. So if you've got ADHD and these other general executive dysfunctions and you're managing that, the demands are very high. So we need to provide additional support in that context. And when we're thinking about adults demonstrating symptoms for the first time, we want to listen. There's a lot of other reasons why they may be showing these symptoms. So I want to give the example of folks starting on Trikafta. They may be noticing more neurocognitive changes. And I think neuropsychological evaluation is especially helpful to refer to in that context. Last but not least, older adults. We have very limited research in this area, in ADHD and in CF. We know that there's no age in which ADHD becomes inactive, and we are also dealing with a cumulative lifelong impact of challenges in struggling with these symptoms, particularly if it's not diagnosed. Something that also really is unique to the older adult period is a lot of changes in supports, relationship concerns, loved ones passing away, partners not being around, moving, adult children moving away. And there's also depression that's at higher rates at this level, at this age group. We know that age-related cognitive changes also overlap with symptoms, and we also know that there's an increased risk of dementia with folks with ADHD. And so in terms of how we can help, this is an area first that needs a lot more research, but we can use some of the same interventions that we're using for our adults with our older adults and really focusing in on also treating comorbidities, especially depression. I think the neuropsych evaluations are especially important too at this phase if we're trying to disentangle, is this dementia or is this normative aging or is this ADHD that was just never diagnosed? And we can also really focus on helping our CF seniors access supports, really connecting those folks. Technology is sometimes a barrier, and we have all these amazing resources in the CF community, but a lot of them are technology based. So taking the time to walk people through how to look up this information or printing things out for them in clinic can really help. So I've gone way over time, but I appreciate you all having me here today and happy to answer any questions. There's a lot more to be done in this area.
All right, so for those of you that missed the disclaimer at the beginning, I am not Dr. Mary Lindell. Unfortunately, she was not able to join us, so you get me. I am not a pediatric psychiatrist. I am the mental health coordinator at the pediatric mental health coordinator at Nationwide Children's Hospital. We are a somewhat fairly large center with a little under 300 kids. And we have been collaborating with Dr. Dell for a number of years on some research. And so she said, let's pull it out and see what we can give everybody some preliminary data on things that we've been doing. So bear with me. This presentation started on Wednesday. It's Friday. I have no disclosures other than the fact that the CF Foundation supported financially some of the costs to be attending the conference this year. All right. So Lily did a great job of painting the picture of what the neurocognitive effects of executive functioning challenges are and ADHD. I'm going to delve a little into what it's like to be a mental health coordinator and dealing with ADHD in clinic, both pre and post Trikafta or ETI. So why in the world do I have a picture of adorable chubby baby legs? Well, and as a pediatric mental health coordinator, I work both in our baby clinic and in our peds clinic. So I get to see them when they're this small. And I'm there when we have all the discussions where we start terrifying the parents that they have to be ingrained from day one, feed your child, keep that weight up. And we know that one of the biggest threats to weight is that ADHD diagnosis and having the treatment using stimulants and various forms of stimulants medication. All right, so crazy, to treat or not to treat. Why in the world would we say not treat ADHD? Like, why would we not want to treat CF? We just learned about all the benefits and all the ways that we can help and support them. After all, we can have better control of symptoms, help with management with the CF therapies, better performance at school. Children at home, their parents are less likely to want to kill them, according to the parents that come home and tell me. And believe me, I know I have a 14-year-old one at home. And also the guilt of, I can't get my act together. And it's a little validation of, there's a reason why you're having trouble getting your act together to figure out this pile of meds on the table. It is a big deal and it is hard. However, I have these discussions in clinic all the time. I already take too many meds. I don't want to take one more. I know I should, or even from the parents. I don't want to have to track down one more prescription with the pharmacist. I have spoken to many people this week, and I know that finding behavioral health providers is a huge challenge. I come from Columbus, Ohio, and it is a pretty big town in Ohio, but not all of our patients come from Columbus. We cover all that, the quiet corner is what we call it, in that southeast part of Ohio where there are very few to no resources. So sometimes there are no providers to be found. I can't find behavioral health providers. I can't even find them pediatricians sometimes. So that is another barrier that we have this discussion in clinic. And then we have long wait lists. At Nationwide Children's Hospital, we have a booming behavioral health department. We also have a very, very long wait list. So if I were to put you on your wait list for psychiatry, we're talking minimum 8 months, roughly. And most parents will look at me and say, well, that's the school year shot. So I can't wait that long, or I'm not going down that road. And then, of course, the concern for all the side effects. And this can come from the kids, and it can come from the parents. The kids, I want to grow. I want to play basketball. Parents, I don't want to fight them to have to eat all the time. So where do I send them? Once upon a time, when I first started working at Nationwide Children's, we had a psychiatrist that was affiliated with our clinic who actually showed up in clinic and met with the patients, and it was a beautiful thing. I no longer have that. Do we have psychiatrists at Nationwide Children's? Of course, but as I said, we have a long wait list. Community psychiatrists, love to send them to those too. We have insurance issues. Most of my patients are on Medicaid. How many psychiatrists take Medicaid? One, none. Real problem. Absolutely real problem. I have gone down the rabbit hole of trying to spend hours upon hours of finding someone to see this child to prescribe medication, and they're not to be found in that particular person's neighborhood, community, 1 hour, 2 hour, 3 hour bubble around them. So I send them to the pediatrician because that's what we have if they have a pediatrician. We also have that slight problem where our care centers are everything, right? Including we are the pediatrician that does all the shots and everything else. So then we have the pros and cons of controlling ADHD symptoms versus controlling the CF symptoms. I get a certain look upon my dietitian's face when I say, guess who was diagnosed with ADHD last week? And it's not a happy look of, oh Lord, what do I have to do now? This is a great fear for our team members, especially our dietitians, and then the parents as well. However, we can't predict, as far as I can tell, who's going to experience these side effects of appetite suppression, because every once in a while, I am shocked by people come back and say, nope, my kid eats like a horse, breakfast, lunch, and dinner, and I would never have predicted that. So you never know who's going to have those side effects and who isn't. And we can only know by trying. So hard to guess. So in our clinic, whenever we have a patient whose growth chart looks abysmal, or we have a growth chart where someone was started on ADHD medications, specifically stimulants, I tend to be invited by the dietitians to join them. So we go in together in clinic and have the problem-solving discussion of how are we doing, what are we eating, how is this working, do we see the appetite suppression, what do we need to work around? So all of these are ideas of things of how we make it work. And this is a conversation with the dietitian, the parents, the provider, myself, and the kid. What is the kid willing to do? Also depends on how old they are. So calorie supplementation, obviously, hey, can we throw a Pediasure on your tray at lunchtime? Nice and easy, see how that works. Mom, can you throw on a few more pounds of butter when you cook the noodles at dinner time? Can we get a snack at school? Can we get a snack after school? Can we get a snack before we go to bed? Throwing them in wherever we can. Bigger meals when the stimulant dose has worn off. Of course, this only works if you're not taking an extended release version. So maybe a huge breakfast and a huge dinner, or maybe they don't really eat lunch, but do they eat when they get off the bus? And then I feed them again closer to maybe 7 o'clock when dad comes home. And then looking at switching from long-acting dose to short-acting dose. Maybe I want it to wear off so that they will be hungry. And parents have a huge input into this, because if we try this and they say, no, they came off the bus, I can tell it wore off, and it was so horrible from 4 o'clock until 8 o'clock when they went to bed. No, we cannot do that. It's a negotiation. We have to figure it out, and everyone has to be on board. And then going back to, okay, if the PCP or the pediatrician is prescribing medications, can we switch to something that's not a stimulant? We know that stimulants are more effective. Can't we try something else and see if that works any better? Simply wait. I've had a few people tell me, oh yeah, their appetite can return after a few months. I'm still waiting for that one to occur. Add an appetite stimulant. Oh, I forgot the T there. Remember, since Wednesday. Adding a little periactin. Something to get that appetite going. Take medication breaks during weekends, school breaks, and summer, giving them as much time off as possible to counteract the I'm concerned about weight and growth. So what happens to this picture when we add ETI or Trikafta? So I have been part of a research study at Nationwide Children's where we have been tracking how all of our patients have been doing since they started ETI in terms of their mental health. And it is a very large study, longitudinally tracking each of them for 5 years. And as the age keeps going lower and lower with Trikafta, it just keeps going and going. We've started pulling out little pieces of information. And so I had already started this, thank goodness, before this week to look at what does ADHD look like in the first year. So as I said, we have this longitudinal study going. Anyone who is prescribed ETI is eligible for taking it. We do not have a control group. All the data about mental health diagnoses and all the pharmacy information is pulled out through chart review. For this particular focus of today, we were looking at only pediatric patients, remembering I'm the pediatric mental health coordinator, and only focused on the first 12 months after they started Trikafta. So we're looking for anyone who has a co-occurring diagnosis of CF and ADHD. So as part of that study, we have roughly, it's rolling enrollment. So at one point we had somewhere around 326 patients, and about half of those were pediatric patients, I believe. 24 patients between the ages of 6 and 20 had a diagnosis of ADHD. About majority, half and half, are male and female. Patients tend to be diagnosed by some type of mental health coordinator. It could be a psychiatric nurse practitioner. It could be a community psychiatrist. It could be a miracle if I actually got them into a Nationwide Children's Hospital psychiatrist and or the primary care physician. Sometimes I got them into a neuropsych evaluation so that they had a little bit more information to go to the school and talk about learning and styles and resources. So, of course, it would be so easy if everyone just had ADHD, but of course, that's not the way the world works. So we have some patients who have autism and various developmental delays. And then we have a lot of complicated learning disorders, mood disorders, PTSD, nothing clean cut in this world. And ADHD, that's how it goes. So 41% were linked to behavioral health providers for counseling. So at baseline, when we started our study of Trikafta and mental health, we do our darndest to get them on day one, and as in the day that they start drug, and they start drug at our center, usually a few exceptions in clinic, where the pharmacist goes over a big educational session with the parents. So at baseline, the majority of our children with CF and ADHD were not using medication. 46% were using medication, and we had quite a range of stimulant and non-stimulant use. So we know that we've been talking here at NACFC for the past couple of years, what is Trikafta doing to our children's and adults' mental health? So what do they look like a year later? So we have some kids who have no change in terms of they had no change to their medication. Some that started medication, some that increased medication, changed from one medication to another, or stopped. And I know the stopped medication was because the particular teen really didn't like the side effect, the little blunting of affect, and just wasn't on board with that and said, we're done. So the largest group of increased their dose, it is not clear. I don't think we can clearly say why did they increase their dose. There is so many things going on. They got older. They started school. They ended school. One particular, they've been going without for so long, or they've been trying to do it with a lower dose, and they finally got into their appointment to see their PCP and increase their dose. So many reasons of why they could have increased their dose or started their medication. This will be part of what's coming next as I get a chance to dive into all of this, and we're not there yet, but it's coming. However, I felt like it was really interesting to look at the kids who started medication. So what happened that all of a sudden they weren't on it and now they are? So 27%, remember we're dealing with small n numbers, is actually only 4 kids. So for the first kid, he had already been on it before. He just went back on. Pretty straightforward. Second child was newly diagnosed at 10 months post-Trikafta. They'd been sitting on one of those waiting lists, so symptoms had been there for quite a while, and we were just waiting for them to get into their appointment. Child 3, newly diagnosed 1 month post-ETI. Again, symptoms been going on for a long time. That was just when we had confirmatory diagnosis and when they were able to start medication. Child 4. This person was going to school for the first time. Kindergarten year. I'm sure for some of us who work in clinic or have children, when are parent-teacher conferences? November, October. When do all the parents come to the pediatrician saying, my teacher said my child is having problems? The day after, right? Been doing this long enough, we can kind of set an egg timer of when this is going to happen. But this child also started Trikafta at the exact same time of that the family was noticing that there were changes in their behavior. So they noticed significant clinical benefit in their CF symptoms by taking Trikafta. And as you can see where the arrow is, there's a slight little drop, but then they kind of plateaued a bit and seemed to be in a nice weight, which this is their growth chart, or their weight, but they're currently in the green one's the 75th. I know it's hard to read. They started ADHD stimulant with improvement in behavioral regulation, and the parent was pretty convinced that this was the reason. Trikafta was the reason. Did ETI cause ADHD? Well, correlational. Timing works. Parent data, the teachers backed them up, said, yeah, she's tough. child was in that first year, and as we know, we've got a lot of new demands, learning how to go to school and what to do. But we also know that when you dig into the chart review, this child did not have a halo. And there were several past referrals to feeding clinic, sleeping clinic, behavioral health, several of these over time. So, we know that there have been a history of behavioral health issues. So the nice thing, going back to the weight chart that I had, was that we know everybody is really concerned about what Trikafta is doing to weight. And we see that with the older kids, maybe older teens and the adults, that they're definitely gaining weight. And we notice it in the first year. When I'm working with the dietitians, what I'm hearing from them, especially as we're going all the way down to 2, is you're just not seeing this dramatic launch of weight. So for these little kids who might be early diagnosis, hopefully, and they're 6 and 7 and 8, when they start Trikafta, we're not seeing this tremendous takeoff of gaining weight. And therefore, all of the concern about putting them on stimulants is no different than it was prior to the appearance of Trikafta. And all those things that were on that list before of putting the butter on and adding the Pediasure and changing to stimulants or going to short acting are still very valid things that are on the table of what we have to negotiate with the pediatricians and with the parents of, how are we going to make this work and keep them healthy? So this is my analogy that I use all the time in clinic. So by a show of hands, if you work with the kids, have you had any parents when they've started on Trikafta and the parent has come back and said, "Oh my goodness, this child has so much energy"? Yeah. So this analogy is what I talk to the parents about. If we take off the onion layers of you feel better, your stomach isn't bothering you, you're not feeling slowed down because of respiratory issues, and you can run with all your friends. If we take away all of these, I don't feel good, and they feel good, oh my Lord, do they have energy. And with this new group of the 2 to 5-year-olds, this keeps coming up because they say to me, "I think my child has ADHD. Oh my goodness, they have all this energy and I don't know what to do with them." And I have to do a lot of validating, normalizing. What does a 4-year-old look like? When you dropped your 4-year-old off at preschool, did they look like they fit right in or did they stand out? And these are great questions to ask their teacher. Is this the kid who just blends right in with their energy level, or are they the kid that's just a little bit above? So these are the conversations that we have in clinic as we're trying to tease apart what is what, how do I get them healthy, how do we balance the CF needs, their weight needs, and control their ADHD symptoms in a way that we can keep mommy happy, the kids happy, the medical team happy, the new dietitian from killing me. Really, I really get looks. So in terms of the research that we're pulling out, we have a lot to do. We have a lot to pick apart. We know that we're not screening for ADHD specifically, so we're pulling this information from chart review of people who have diagnosed it, not me. We also know that we're getting the pharmacy history from people that, sort of second, third hand as we do drug reconciliations and things like that. So we have a lot to go to work on this to flush things out. I think part of my takeaway is from the mental health coordinator position in a clinic setting, that this decision is not made in a vacuum. You cannot decide how to treat both their CF and their ADHD without including everybody. And believe me, those teenagers have opinions about how they want to do it or how they don't want to do it. And they will tell you, I don't feel like me sometimes on certain kinds of meds, or I don't like the fact that I'm so skinny. I'm worried about that I'll never be able to catch up with my basketball friends because I'm not tall enough. They have opinions, and even the little ones have opinions too. Parents, plenty of input. We have to join with them to make a plan that's going to work to try to address all of their needs. And sadly enough, sometimes that decision is not to treat their ADHD with stimulant medications. Sometimes it just doesn't work. And we have to use the environmental supports through school, through those 504s, through those teacher interventions, through counseling, behavioral training, all of those other tools that we have in our pocket. So regardless of what is causing these ADHD symptoms, whether it has any drug impact or not, we need to treat their mental health needs and figure out the best way to do it. So that is all. And now I get to hand it over to Dr. Scher.
All right. So I think, as we kind of moving through our lecture, right, the presentations, I think we're really, we are presenting some of the data, but I think hopefully just highlighting, right, that, that there's increased need to really study this, right? We've, I think, illuminated the increased rate of depression and anxiety in CF, right? And, there's obviously still a lot of work to be done there. But I think now, right, we can also be shifting attention, and we are shifting attention to some of these other areas. So I will be talking a little bit actually about ADHD, but more about just, cognitive dysfunction in CF and in general. And of course, I'm a psychiatrist, so I will have to talk about medications. Okay. Some reason. Oh, here we go. Okay. So I do have some support from the CF Foundation, but nothing related to this talk. So the objectives will be, we'll discuss, kind of really review and maybe broaden just a little bit further differential of cognitive dysfunction in people with CF, highlight certain etiologies, and then we'll discuss treatment of ADHD. And I don't think there's going to be any surprises in how I'm going to recommend to treat ADHD, but maybe we'll see. All right. So we have reviewed some of the cognitive domains already, but I just wanted to put this nice table, right? So when we talk about cognition, right, and this is what would be sort of assessed in the neuropsychological evaluation in general, which as a psychiatrist, I also will not do, right? But we think about sensation, which includes kind of all multisensory modalities. We think about perception, right? Object recognition, organizational strategies, motor skills and constructions. For example, we test that sometimes even in the office by copying, right? Like copying the figure, drawing, other praxic skills. We're talking about attention and concentration, right? We already talked about the selective attention, right? Paying to one thing at a time, or sustained attention and vigilance, like you're all hopefully doing right now. With some destructibility, I'm sure. Memory, right, which has multiple domains. Executive functioning, right, where our frontal and prefrontal lobes, right, are really involved. Reasoning, problem solving, skills management, processing speed, and language and verbal skills. So these are roughly our cognitive domains, right? And I think some of them have already been highlighted. So there have been some even earlier studies, they're not a lot, but there have been some studies on cognitive dysfunction or functioning in people with CF. These are smaller studies, right? And the first kind of, factoid is from a study from 1990s where they have found cognitive impairments have been observed for certain domains in people with CF, attention, which we already discussed, memory, and executive function, right? These are smaller numbers. And I also want to say that overall intellectual functioning in people with CF is the same, right, as healthy controls, right? But just some of the domains can be affected. And these are older people, right? Also, people with CF with severe disease, right, defined as FEV1 less than 40%, experience increased daytime sleepiness and perform at the level which is 60% of the healthy controls, right? And of course, patients with end-stage lung disease, right, even further deterioration, have the greatest impairments in verbal memory and executive function. Right, so even though we have some evidence that there might be some differences early on, obviously living with progressive chronic illness, right, with impaired oxygenation of the brain and exposure to hypercapnia is clearly not helpful. And we also know that, let's say, other patients, right, patients with other progressive lung conditions, right, when I see people presenting for lung transplant evaluation with IPF or COPD, many patients do report cognitive dysfunction, right? So definitely hypoxia plays a big role. This study was published in 2017, and it looked at children with CF, compared them to children with another chronic illness, inflammatory bowel disorder, and 30 healthy children, ages 7 to 17. And they did find that children with CF and IBD both had impaired performance on attention and some memory tests, and a bit even more so in people with CF, right? Again, not surprising, right? Even if we think about just the illness, right, from perspective of exposure to some sort of chronic illness, right? IBD also, it's not a great disorder to have, right? But obviously CF does encompass more organs, right? It's obviously diagnosed hopefully at birth, right? IBD declares itself later on. So, but there's definitely this emerging studies that we see that do indicate, right, this persistent dysfunction. So just let's think about kind of the broad differential of cognitive dysfunction in people with CF, right? So when our patients of any age, I work with adults, right? So come to us and report some problems with attention or memory or executive functioning, right? What should we just think about, right? Let's just open up the differential. Well, just as I said already, kind of just living with chronic illness, right? And all of its multiple effects that it has on the body, but also the stress of caring, right? For the challenges that have to do with living with chronic illness. Then CFTR functioning in the brain. And I will talk a little bit more about this on the next slide. We do know that CFTR gene is expressed in the brain. We have some hints about some of it functioning, but not all of it. Neuroinflammation. I'm going to talk about it as well. But that's like a very sexy topic in psychiatry, like everything. If you ask, what is the pathophysiology of anything? Say inflammation is going to be correct. Depression, delirium, dementia, ADHD, right? So, and we're talking about CF and inflammation, right? So you can definitely see that overlap. Depression, anxiety, right? So anxiety and ADHD, I mean, sometimes it's hard to understand which one is which. Untreated depression definitely will present with cognitive concerns. And we know that our patients have increased risk for depression and anxiety. Sleep disruption and disturbances, right? None of us, if we don't sleep well, we're not going to be performing at our best, right? And we're going to have a great lecture following right after this one about the sleep. Vitamin deficiencies, in particular vitamin E, which is of course fat soluble, right? It's antioxidant. It's actually very important to have that at a good level for optimal brain functioning, right? Going back to malnutrition. Other comorbidities, diabetes that we heard a little bit about, obstructive sleep apnea, right? Which sometimes underdiagnosed, not treated, thyroid dysfunction, eventually renal dysfunction. All of this can affect, right? And does affect brain functioning. Highly effective modulator therapies, right? I mean, I think there's definitely some signal, and we're still not sure exactly what's happening, but that's definitely part of the equation. I mean, ADHD, I had to put it there because that's the topic. What about substances, right? How many of our patients do use cannabis, right? To help with the weight, to help with sleep, just because they live in California, right? So, but it can definitely affect the concentration, right? So it's very hard to treat ADHD if somebody's using cannabis, right? Or other substances, obviously. Hypoxia and hypercapnia, right? I think it's self-explanatory, but it actually affects neuronal functioning. What about our patients who then go on to post-transplant, right? There are further potentially cognitive challenges. The medications that they're exposed to, including immunosuppressants and steroids. And then aging, which, we are seeing more and more of it. And actually neurodegenerative disorders, like things like dementias. How many of you have seen patients with CF and dementia so far in your clinic? Can you raise hands? Okay, yeah. And I see, of course, Stanford, right? We have had some patients. We have patients with CF and Parkinson's disease dementia, CF and Alzheimer's, right? I mean, we're going to just see that, which is kind of scary and exciting at the same time. So CFTR in the brain, we know it's expressed, right? And there's a strong and widespread neuronal expression of CFTR in the developing central nervous system. And it seems like it affects kind of how some of the neurons are maturing, right? Especially in the prefrontal and frontal cortex. And that's exactly what's responsible for attention and executive functioning, right? So eventually, grossly, everything ends up exactly where it needs to be. But there's some delay in that maturation. So how is that gonna translate to the cognitive functioning? And it also seems that CFTR is involved in circadian rhythm regulation, sleep, and wakefulness. So just that, again, it affects the sleep, right? So how does that translate to cognitive functioning and ADHD in particular? Fancy neuroinflammation slide. But as I promised, right, so it surely does seem that it's part of the pathophysiology, right? And is it sort of like the causation versus correlation? We don't know, right? But it is part of the equation. And any insult to the central nervous system, such as infectious diseases, right, of course, can provoke an inflammatory response in the central nervous system in the brain, right? So think about our patients who are obviously colonized, right, who have multiple exacerbations, right? It affects the brain. Right? So, and then, right, it affects the cytokines, right? And once the immune system is activated, right, there's some pro-inflammatory, right? So some cytokines are good, and actually they might even help to mature brain in the good way, but there are many bad ones that brain doesn't like, right? And it really sort of degrades the brain's functioning. So it definitely inflammation can promote and inhibit neurogenesis, depending on such factors as chronicity and severity of inflammation. Again, we think about our patients, right, with multiple, colonizations and exacerbations. And this is a beautiful slide, again, because it's important, kind of looking at particularly in patients with CFRD and patients with CF without diabetes, because first of all, it's a great study, and also there's not actually that much is done in the area. But it does show that people with CF and no diabetes, they already have decreased processing speed, right? And some of their aspects of verbal and spatial memory and cognitive flexibility are affected. And patients who have CFRD on top of it, there is actually 40% reduction in processing, right? In processing speed. So there are, again, three major hypotheses why that happens, that there is even poorer cognition in people with CF and CFRD, right? As we already heard, regulation of glucose and insulin, like we need glucose for our brain to function. CFTR, right? Kind of the expression of CFTR, and chronic inflammation. And also all those things affect each other, right? Even kind of my fancy slide was when I threw everything together, right? The differential. These are not separate entities, right? In psychiatry, right, we deal with syndromes, right? We have a syndrome of depression. We have a syndrome of whatever, bipolar disorder, syndrome of ADHD. This is a collection of symptoms. Brain is, I'm biased, but it's like the most complex and most important organ, but pulmonologists, please, don't kill me right now. Right? So, but these are syndromes, right? And so all of those other factors, they're kind of playing together, right? Some of them they're feeding in as a pathophysiologies, they're comorbidities, right? But it's not like this is a separate entities necessarily, right? Likely somebody has this effects on neuroinflammation and depression and ADHD and sleep problems, and it's all coming together. With highly effective modulator therapies, we know that there is some signal, right? There's important signals. We hear from our patients. We don't know exactly that this is the direction it's all going to, but I've kind of through some studies, right? We know that there are definitely case reports, started with case reports of depression and anxiety, right? Another retrospective chart review indicated that maybe there is actually no change in depression per se, although there were some changes in how patients were managed, but a quarter of patients reported sleep problems after initiating Trikafta, right? And in this study of 245 patients indicated actually the most complaints were about changes in body representation and fear of becoming dependent on treatment, but there's not necessarily actually a lot of complaints about depression and anxiety. Few other reports demonstrated that, so the study on the left with 70 adult patients from Germany kind of actually did not necessarily see a change in anxiety, but depression got better. But the case series on the right didn't decade, right? Case reports of patients reporting fogginess and word finding difficulty and memory issues, right? So it will be interesting again to see how this is all going to play together, right? Again, CFTR is expressed in the brain. We know there are some changes. Now we have medication that affects that. I mean, we would think that it's affecting positively, but right, we're not sure. And actually, so why potentially could the highly effective modulator therapies affect brain functioning in general, right? Well, it could be unrelated, right? Correlation doesn't mean causation, could be unrelated. We know that, patients in general have higher risk of depression, anxiety, and so on. There could be effect of CFTR modulators on the brain. There can be physiological changes due to CFTR modulators on other parts of the brain, right? Like now a patient has a lot of energy and doesn't want to sleep at night anymore because, it's not fun. So, right, so there's that. Drug-drug interactions. Let's say somebody was treated, right, for depression, anxiety, and now, right, medication changed the dosing. Something that came out of a great class on Wednesday is actually, which I totally think we all should be doing this, right, drug metabolism, right? Like Trikafta comes in one dose. That's it. Like what other medication do we do that with? Except for Melteon, which is melatonin agonist. Right, but we know it goes through a bunch of CYPs, right? Is it possible for those patients who have a bunch of side effects, right? We actually gave them too much. So we probably should be measuring levels and all of that fancy stuff outside of the clinical data. I'm sure that's where it's developing, right? But other side effects, are we just over-treating the patients, right? Because, they're not metabolizing the medications quick enough, right? And so that they're just toxic on them. So maybe. There's obviously psychological and existential effects of potentially life-altering medications, right? I mean, I'm sure we've all heard about, oh my gosh, I'm gonna live longer, but I haven't planned, right? I haven't saved, right? So just that. And then of course, COVID-19, which, did that happen? And then other world crisis, right? Obviously, right, kind of, that also affects how we all are mentally and cognitively functioning in the world. And then if we move into our post-lung transplant patients, right, we know that all comers, right, after lung transplant, they do have approximately 60% of people after lung transplant have some sort of cognitive dysfunction, right? It's associated with long ICU stay. Some other predictors of post-lung transplant cognitive dysfunction is duration of the surgery, right? Again, being under anesthesia, hypoxia. Surgery itself, it's a very inflammatory state, right? Because it's obviously, right, like the body's cut up and it's trying to heal itself. So it's a huge inflammatory response. Bilateral lung transplant versus single, but all our patients with CF get bilateral lung transplant, and delirium, right? So in general, 45% of lung transplant patients develop delirium after the surgery. And if we look just at patients with CF, it's 25%, but it's still a significant risk factor. Looking at another study, 49 patients were evaluated before and after lung transplantation, and they've noted that 1/3 of their patients had significant cognitive decline. And another small study of 47 patients that included people with CF have noted that 45% had some neurocognitive impairment before lung transplant. Actually, not patients with CF, but this was a very MOCA, right? It's sort of like it's a very easy test. I mean, it's not a great test. It's not going to pick up on those very fine points that we're talking about, but that's good to know. But it's interesting that, for example, after transplant, neurocognitive performance initially worsened, particularly in patients with CF, because I think actually they came in with a better baseline and they were younger. But then it improved over follow-up, right? So they might be the ones who acutely you'll know the difference, but then they bounce back. But overall, right, there is some people persistent and worsening cognitive impairment over time. We also think that immunosuppressants definitely contribute to that, and there's of course not enough done in there. And delirium is, as we know, is a risk factor. Medications, right? So calcineurin inhibitors in particular, cyclosporine and tacrolimus, have very pronounced immunosuppressant side effects, right? The neurotoxic side effects, and also nephrotoxic, right? So they're going to affect your brain, they're going to affect your kidneys, and so that's going to affect your cognition as well, right? So we definitely see that in our patients. But also, other antimicrobial medications can also have a variety of neuropsychiatric side effects. For example, this will be more dramatic, but for example, cefepime is associated with delirium, right? So some medications that we might not kind of classically think about affecting patients in a cognitive way can certainly do so. And not even talking about benzos and Benadryl and opiates, and we're not even going there. And then steroids, right? So, obviously, even before transplant, our patients might, be on steroids for a variety of conditions, and definitely they're going to be chronically on steroids afterwards. But they associate with a variety of neuropsychiatric side effects, right? Yeah, tremor, restlessness, anxiety, insomnia, just sort of like low-grade cognitive side effects, delirium, psychosis, mania, and then with withdrawal, if somebody was on a high dose and then it's being withdrawn, actually patients now have depression, right? So it can go all the way. And the most validated risk factor for development of the neuropsychiatric side effects with steroids is actually the dose. So the higher the dose, and we usually calculate that in prednisone equivalents, the higher is the likelihood. So that's something also to think about. So this is sort of like a broad differential, right? Just all the things to think about when our patients come in to us, right? Before we jump and then happily diagnose them with ADHD, which absolutely true can be done in clinic, right? So I mean, when I diagnose somebody with ADHD in the clinic, right? Obviously I take excellent history, right? Really, but meaning that like I really go through their childhood, right? When did the symptoms, right? When did the symptoms start? How did they function in school? What kind of grades, right, they had? Were they diagnosed with learning disabilities? Were they in special programs? So really kind of understanding that, right? What maybe they were even diagnosed already before. Talking about the substance use history as well, right? Because I mean, I'm not going to be prescribing somebody, Ritalin if they're taking cannabis, right? So really kind of distinct, and obviously thinking about all the other aspects. And then the tool that I found very helpful, and actually that was used in some of the studies that I quoted earlier, is the ADHD kind of self-report checklist, ASRS. Yeah. So that's kind of the one, just Google it and ask the patient, and it's very actually easy to do. And surprise, surprise, right? But one of the best ways to treat ADHD, right, if that's the diagnosis we're gonna come to, is stimulants, right? And we think about methylphenidate-based, Ritalin, and then amphetamine salts, right? It's things like Adderall. And this actually some of the most helpful and effective medications in psychiatry. 70% of patients will respond to those medications. Like, that's actually pretty cool, right? And what really is happening in ADHD, it's the sort of norepinephrine and dopamine are impaired. And so they really release, right? They increase the availability of norepinephrine and dopamine, right? So that the neurons are able to function and patients are able to focus, right? And kind of an executively function. But these actually can be very, very helpful and effective medications. What are the side effects? Well, the most common side effects, right? Yes, potentially the weight loss, right? And appetite suppression. And in adult patients on Trikafta, right? I'm not sure that clinically, to be honest, we've not analyzed the data, but I'm like, we really should. But I'm not sure that we've run across actually concerns that adult patients have been losing weight on stimulants. Sometimes actually it's helpful adjunct. Like, we want them now to lose weight, right? Being on Trikafta. So that actually might be helpful for that. Insomnia, right? It can definitely interfere with sleep. Sometimes it can increase a bit of anxiety. We do want to measure kind of, take a look at their blood pressure and, heart rate. And yes, for some patients, we might need to switch, being ineffective, but it seems like overall, actually, these are pretty well-tolerated medications. Some non-stimulant options are tamoxifen, which only works on norepinephrine. Also alpha-2 agonists, so guanfacine and clonidine, they're especially used in children, right? So kind of we're really worried about the weight loss. And bupropion, kind of, and less so, right? Bupropion, which is an antidepressant, weakly increases availability of norepinephrine dopamine that can be used. Some TCAs, tricyclic antidepressants, that also increase norepinephrine, and modafinil. And again, like, behavioral intervention and environmental interventions are huge. You exercise, so those are definitely very important ones. And there is a great article by Dr. Bathgate, right, kind of again summarizes a lot of these treatments and has beautiful tables, so I've included it here. So some takeaway points, right? So differential of cognitive dysfunction in people with CF is broad. So kind of let's think about that. Let's consider etiologies: untreated depression, anxiety, substance use, other comorbidities, vitamins, hypoxia, medications. But do consider diagnosis of ADHD. It is more common in people with CF. We can diagnose it in clinic with the right resources, and treatment is available. Although, of course, now the shortage of Ritalin because it's Ritalin, but it is available. It can really make a difference. And definitely, we do need much more research in this area. All right. Thank you. And now we'll have a great lecture on sleep and ADHD.
Hi, everyone. Thank you for still being here. My name is Arthi Shakate. I'm an assistant professor of pediatric pulmonology and sleep medicine at University of Texas Southwestern Medical Center. And I'm going to be talking to you about sleep disturbances in people with cystic fibrosis and whether this could be a potential risk factor for all the increased risk of ADHD and cognitive dysfunction, executive dysfunction that we're talking about. So I have no relationships to disclose. So my objectives for this talk are, as stated, so to learn about sleep disturbances in people with ADHD and in those with CF, and understand how both groups can be at increased risk for certain sleep disorders, such as obstructive sleep apnea, restless leg syndrome, circadian rhythm disturbances, and then briefly look at what is happening in the post-ETI or post-highly effective modulator therapy era. So we know from data that 25 to 65% of children and adults with ADHD experience poor sleep. This includes things like insomnia, restless sleep, frequent awakenings, increased arousal, snoring, daytime sleepiness that have come out of questionnaire data in this population. Actigraphy and polysomnography or sleep study data show that these individuals have prolonged sleep onset latency, a very high stage shifts index, increased N1 sleep, all of which are signs of sleep fragmentation. And then they have poor sleep efficiency, frequent limb movements during sleep, and a high apnea-hypopnea index, which is suggestive of obstructive sleep apnea. Obstructive sleep apnea in particular is present in 20 to 30% of children and adults with ADHD. RLS, restless leg syndrome, is present in up to 43% of children and 30% of adults. And then delayed sleep-wake phase disorder is also a common phenomenon in this population, especially having an eveningness chronotype. And more objective measures I've looked at that as well, including a delayed dim light onset melatonin. And as we've seen already, there are a lot of comorbid conditions associated with ADHD, like anxiety, depression, oppositional defiant disorder that can worsen these sleep disturbances, as can medications that we're using to treat ADHD, such as stimulants. Sleep disturbances in those with ADHD, understandably, are associated with poor quality of life and daytime functioning. And they're also associated with the development of mood disorders, such as depression and anxiety, and, of course, increased parental stress. And we know that, with these sleep disturbances, so there is a sort of reciprocal relationship almost, where you have kids with ADHD who have sleep disturbances, which then worsens their ADHD symptoms and makes them more at risk for having anxiety, depression, and all of that. But you also have primary sleep disorders like obstructive sleep apnea and restless leg syndrome that can present with ADHD symptoms or with ADHD-like symptoms. And so it's very important to kind of tease out what is the bigger player and what is affecting some daytime functioning. And there are several treatments that have been, reported or tried, including behavioral interventions, things like parent education, bedtime fading, cognitive behavioral therapy for insomnia, use of melatonin, iron supplementation for kids with and adults with restless leg syndrome, clonidine and other hypnotic agents to help with insomnia, and then, of course, light therapy, chronotherapy for the delayed sleep-wake phase. So I want to shift gears now a little bit and talk about sleep in those with CF. So we see similar numbers of poor sleep quality in our patients with cystic fibrosis. So up to 65% of both children and adults with CF report some difficulty with their sleep, whether it's difficulty with sleep initiation, waking up in the middle of the night, not getting restful sleep, snoring, difficulty breathing during sleep, and restless legs. And again, data from actigraphy and polysomnography confirm a lot of the same things that we see in our kids with ADHD. So prolonged sleep onset latency, poor sleep efficiency, not getting enough sleep, increased sleep fragmentation, and of course the unique issue of gas exchange abnormalities. So nocturnal hypoxemia, hypercapnia, which is unique to CF. And then obstructive sleep apnea, delayed sleep-wake phase are all at increased, found with increased frequency in our CF patients as well. And there's data to suggest that these sleep disturbances are associated with lung disease severity. So you see that graph there on the right. It is looking at lung function and sleep efficiency. And you can see that there are differences based on lung function, where those with moderate to severe decrement in their lung function have lower sleep efficiency compared to those with normal lung function, and certainly compared to controls that don't have CF. So this other paper looked at factors that may be associated with reduced sleep duration and poor sleep efficiency. And one of the big things that you can see is that presence of a behavior disorder is associated with reduced sleep duration and reduced sleep efficiency. And there are some other ones like CF-related diabetes, which we alluded to earlier in this talk, nocturnal tube feeds, and then having low baseline oxygen saturations during the daytime. And many of these same factors, including presence of a behavior disorder, was also associated with prolonged sleep onset latency and increased time spent in wakefulness after sleep onset. So this table here is data that I collected while I was a fellow at the University of Michigan. We did a large-scale retrospective review of polysomnography data in our children and adults with CF. And we looked, and then we all compared them to referred non-CF controls. And what you can see, I know it's a little bit of a busy table, but the big take-home points are that people with CF had higher apnea-hypopnea index, which hopefully you can see with my mouse, maybe. Okay, higher apnea-hypopnea index. They also had lower sleep duration, greater sleep fragmentation, worse nocturnal oxygen saturation as compared to those without CF. We then dove in a little bit deeper and to look specifically at obstructive sleep apnea among those with cystic fibrosis. So this is data from other centers, and then I will present our data. So what we knew going into this was that OSA was pretty common. So 70% of infants and preschool children with CF were noted to have OSA. The apnea-hypopnea index was higher among children with OSA as compared to non-CF controls. When you get to the older child and adolescent age group, OSA was found in 65%, including in those with preserved lung function and mild lung function. And this was a meta-analysis that came out recently in 2021. And then when you look at both children and adults, and this is data that we published a couple of years ago, 53% of both children and adults had OSA based on polysomnography data. And the odds of having moderate to severe OSA was 3 times higher, even in the CF group, even after controlling for things like age, sex, race, and BMI. And we found, and then there was a recent paper that looked at OSA specifically in adults, so only adults, and they found that 40% had OSA based on prospective polysomnography data. So all of the other ones are primarily retrospective, and this particular one was prospective. And there are several risk factors that we were able to identify, including tonsillar hypertrophy, chronic rhinosinusitis, being overweight or obese, having poor lung function, and then low daytime oxygen saturation. So this graph here looks specifically at our population at Michigan. And what we found, so we had lung function data from 34 of our patients with cystic fibrosis. And then we also looked at something called Brassfield scores. For those of you that don't know, this looks at findings on chest x-ray. And we had one of our pulmonologists score the x-ray who was blinded to the results of the polysomnography data. And their scores range from 3 to 25, with lower scores reflecting worse disease. So what we found is that the apnea-hypopnea index did not correlate at all with lung function or the Brassfield score, whereas all the other measures of oxygenation did. So what we concluded from that was that daytime measures of CF lung disease severity may not be sufficient to necessarily detect OSA severity in this population. And so, okay. So this graph on your right-hand side is another graph from our paper where we looked at different measures of lung function. So normal lung function is up here, FEV1 of 90. Then you have mild reduction, FEV1 of 70, and more severe reduction lung function, so FEV1 of 50. And what you can see is that for every increase in your AHI, the slope becomes steeper and steeper in terms of your oxygen saturation nadir during sleep. So what this told us was that not only is sleep apnea worse in those with CF, it also had a much greater impact on nocturnal oxygen saturation. And we all know that hypoxemia is a risk factor for things like right heart failure and cor pulmonale and all of those things in patients with CF. So this was pretty important. And we also found similar sort of curves for sleep fragmentation, sleep duration. And then lastly, there is, some data that, looked at the impact of having OSA on quality of life. And understandably, the children and adolescents with CF scored much worse, not just on the CFQR, but also on the OSA 18. So OSA does have a much greater impact, both on their oxygenation, the quality of their sleep, but also their quality of life. So one of the questions when I present this data I'm always asked is, what about in the era of highly effective modulator therapy? And so I wanted to share some of this data. So this is data from the University of Texas Southwestern. So we looked at retrospective data from our pediatric patients with cystic fibrosis. And we looked at data from 2012 when FDA approved ivacaftor to 2023. And we had data from 49 pediatric patients with cystic fibrosis. 57% had OSA of this population. 43% were on highly effective modulator therapy. So the graph on the right kind of shows you what the distribution of the different medications were. Most of them were on ETI or Trikafta. And were on modulator therapy of some sort for an average of about 2 years. And then another 54% of our patient population were started on a modulator after their sleep study. So we looked at the ones before who were on modulator at the time of their sleep study. And what we found is that children with CF who are on a modulator had 4.3 times greater odds of having OSA compared to those who were not on a modulator. And tonsillar hypertrophy was a risk factor for OSA independent of modulator status, with an odds ratio of about 6 times in that population. So what about adults? What is the data there? And so we've had several studies come out looking at the impact of modulators on sleep in adult patients. And we know that a study by Zhang et al. Just was published recently found that a quarter of adults endorsed new sleep symptoms, and a third of adults had persistent sleep symptoms after initiation of ETI. And then there are other papers that show difficulties with attention, memory, insomnia, depression after initiation of ETI. The paper by Meltzer et al. Showed some subjective improvement in sleep onset latency, frequency of nighttime awakenings, daytime sleepiness in 34 adults, but more objective data that was presented by Weltzner didn't support that. That there was really, no changes in sleep duration, efficiency, or latency, at least by polysomnography, in patients before and after ETI. So, what do we know? So we know that patients with CF suffer from high numbers of both ADHD and sleep disorders. Both comorbidities have been independently associated with more severe lung disease, an increased frequency of mood disorders such as anxiety and depression, and poor quality of life. Poor sleep is a problem among those with CF, even in this era of highly effective modulator therapy. And sleep disorders such as obstructive sleep apnea and restless leg syndrome can often mimic symptoms of ADHD. So could poor sleep be the link between ADHD and CF? I hope I've convinced you a little bit of that. And there's, of course, more work that needs to be done to, further flesh out this idea. I'm so glad, as a sleep physician and a pediatric pulmonologist interested in CF, that we're having more focus on sleep issues in those with CF. And I hope we have more papers on this soon. I'd like to acknowledge my team at Children's Health and UT Southwestern Medical Center for all their support, and I'm happy to take questions.
Let's try that now.
Okay.
All right, so for those that would like to ask questions, feel free to come to the mics in the aisle. Otherwise, we also have some questions from the app. So I think some of this was addressed earlier, but just to emphasize this, one of the questions was, which ADHD screen do you guys like to use in clinic?
I don't think any of the mics are working.
Yeah.
Just shout.
So Dr. Cher shared one, that one I think was developed by the WHO, and you can, I think, just Google WHO, the adult self-report scale is great. For kids, I really like the Vanderbilt scales. There's also, I want to just point you all to another resource. There was a Indiana University course broadly on mental health, but we did do one on mental health under age 12, which does have some great resources for broadly mental health under 12, but also some of the ADHD screeners. It's free, it's available there. But those are the big ones. And people, I think, a lot of times are scared to diagnose ADHD, but I emphasize that it is diagnosed based on behavioral symptoms for a reason. You do not have to be a neuropsychologist to diagnose it or evaluate it. It is done routinely by pediatricians, other nurse practitioners. It is done by psychologists. Anyone who's able to do diagnostics can learn the skills to diagnose it.
I'll just add that I send my kids to neuropsych testing for specific reasons sometimes when the kids are having trouble in school and they're trying to figure out what accommodations are specifically appropriate for this individual's learning style. And I want the parent to have concrete recommendations that are valid for this particular child to take with them and take back to the school. So there is a purpose for that if the family finds that useful. All right, so Dr. TikTok seemed to make an impression. If teens are on Dr. TikTok for their ADHD info, what would you suggest they check out as an alternative with a little bit more facts in there?
So, lest you all think I hate TikTok, I'm actually not on TikTok, but I don't hate TikTok. I actually think it's fantastic. It's a great resource. So there are a few, well, I think one of the things that I really appreciate about the medical community and mental health community is that there are a lot of providers who have gone on TikTok and Instagram. I haven't been brave enough yet, but maybe some of you all will be. But so there are a few good ones. On TikTok, I'm terrible with remembering the name, so let me give you one. So Dr. Sasha Hamidi, she's at the Psych Dr. MD. So she's a good one. You can direct them to that. There's actually some good articles on CHAD too about TikTok. So that's a child ADHD organization. So, and another one is at Dr. Hallowell, Hallowell. He's another good one. So use it. If they're on it, that's a great place to direct them to. And there's a lot of other great websites and organizations, which y'all can Google. But those are some, I think using that, the providers and the people who are specialists who have taken that step to make that the evidence-based information accessible on the resource that kids are using, I think direct them towards that.
And also, I had some, kind of some of my slides, right? I actually borrowed information from the pamphlet produced by CF Foundation, just like because it is prevalent, right? I mean, just having those out in clinic and giving them out, it's like written very easy, very easily. So I mean, I think that can be just a good, resource. Like this is what the doctors are saying, but what do they know? So. Yeah.
Artie, this one's for you. Would you recommend sleep studies as standard practice for peds patients with CF, and at what age to aid with prevention?
So that's a great question. Thank you to whoever asked that question. I am all for doing sleep studies in patients with CF. My research over the last several years has found that really they're not great daytime measures that we can use to figure out who is truly at risk for these sleep disorders. There are lots of studies that have asked about snoring and daytime sleepiness and all of that, and nothing really seems to be able to predict OSA or even restless legs in this population. So I'm all for doing that. I understand that access, availability are all issues when it comes to doing sleep studies in everyone with CF, as is, the discomfort of being in a sleep lab and doing that. And so we have home sleep apnea testing that's, widely available in adults. And, a lot of our, adult sleep providers are using that even in patients with CF. I'm hopeful that, it gets expanded to the pediatric population soon. Thanks to the COVID-19 pandemic, lots of people have had to do it. And we're hoping that the American Academy of Sleep Medicine, recognizes it as a diagnostic modality so we can start delivering it to more kids.
All right. After diagnosing ADHD in clinic, where do you send people for treatment, knowing psychiatrists are so hard to get into and CF doctors will not prescribe? So I think this one is depends on what the families wish to accomplish with their treatment. If they're looking for primarily medication and not all of the other examination of executive functioning skills and things like that, you send them one place. If they really want a breakdown of learning styles and does this interfere with school and how do I manage behavior, we send them into different directions. So that is the conversation I usually have with parents. Do you want, are you the one that wants help? Nationwide Children's has community education that is a ADHD Academy, which has modules that I encourage the families to do. So I'll send them links to go do those. If they want more, how do I deal with the behavior? Sometimes I set them up with counseling in the community or attached to Nationwide Children's. And if they need meds and they want it yesterday, then I say, okay, let's hit the PCP. That's the fastest way I can get you in. And if that, and if that obviously doesn't work, please call me and we'll work on another plan. So this one is for Dr. Scher. Is there evidence linking inflammation fluctuations to cognitive functioning in people with CF? And do we see the same high rate of genetic transmission of ADHD and CF as we do in general population?
These are all great questions. I think they're research questions at this point. I mean, they're wonderful, and I have not come across articles that like have looked at it in particular because we just do not have enough data, but those are exactly the questions to be asking. I also just briefly saw that somebody was asking me about the title of Dr. Bathgate paper. So it's Management of Mental Health and Cystic Fibrosis, and it was published in 2022. And it's like helpful for management and diagnosis of pretty much all mental health conditions. So that's a great tool.
All right. Is ADD also increased in CF, and how is it recognized?
So ADHD equals ADHD, right? So it just sort of, you know, because ADHD can have inattentive type, right? And this is what ADD is versus hyperactive type, right? Versus both. So ADD equals ADHD.
All right. Any preferred sources or references for coaching, teaching skills for ADHD patients? What skills to focus on? Do you want to take that one, Lily?
Sure.
So just to be clear, there's nothing specific to CF. However, there's a lot of great resources out there. I really like Russell Barkley's. He has stuff geared towards kids, to young adults, to kind of every age group. And what I really like about some of the resources he has, there's even actually a teacher workbook too, I think, that he has. Like, he makes things very simplified and accessible. Like, I really like reading them. Like, they're not like dry and boring, and very practical. And I think that I know folks don't love reading long books, but he also has a few great self-help books, especially for young adults with ADHD, that you could direct folks towards.
All right. In the studies that reported rates of ADHD in people with CF, did they report rates by gender as well?
They, you know, kind of, they did. I mean, what I remember, and correct me kind of if I'm wrong, right, that there was also male, you know, ADHD was more commonly diagnosed in males than females before puberty. And I think in adults, actually, it was more 1-to-1. That's what I remember. Is that, yeah. Yeah, so I mean, I think some of the studies yes, they have reported that.
All right. This one was for me. I work at a center where I function as both a mental health provider, social worker, and parent skills coach. What are your opinions of a CF social worker participating in a patient's IEP meeting for both ADHD and CF accommodations? I think it depends on what your role has been with the family in respect to managing their CF. If this is something where everybody, how they do their job as a mental health coordinator is very different. So if you're turfing it off to coaching, you know, a life coach, or if you have a counselor involved and things like that, obviously you can use them. But if you feel like you need someone who can speak to both, I definitely attend virtually, usually IEP 504 plan meetings and things like that for our families to address how to coordinate care and have that continual consistency across all environments. So if it falls within the role of what has made sense of how you've been helping the family. So
on the adult side, I mean, I have written letters to help with accommodations in school, and somebody was just like recently sitting in for like a very big important test, and we've written a letter, and you know, they have agreed to accommodation. So definitely, I mean, I think we can help in many ways for our patients to succeed.
all right, what criteria would you recommend for whom to screen in CF clinic, or would you just recommend screening everybody?
Good question.
Sure. I mean, I have my own personal thoughts on this, and I think that the depression and anxiety screening kind of guidelines and development is a really good model to be using for some of these other concerns we're seeing a lot of problems with. We cannot screen everybody, every clinic, every time for all the things. Like, it is just not possible. And so I don't necessarily recommend universal screening. Although for research purposes, that would be fascinating. I think, you know, having mental health coordinators be comfortable using some of those screens when folks are volunteering that they're having attention and focus concerns would be a really great start. I think that especially in the context of things like depression and anxiety, which we do screen for, these symptoms overlap. And so having another tool in our toolbox to be able to kind of more precisely guide folks towards interventions or even treat it in clinic is a great place. But I think, hopefully we'll see more to come in terms of guidelines around that.
So I agree. I mean, I think definitely when somebody comes to you, right? And usually people, in adults, usually people will report, right? So I mean, I definitely kind of further investigating that. But I would also, add somebody who's really struggling with adherence, because we found some of our patients who really struggled with adherence, like those are the ones who, kind of, then we might need to bring up that idea. So, that would be something else on differential.
And I'd also like to add, just like the interplay between sleep and ADHD, if you have someone presenting to you with sleep problems, fatigue, falling asleep in your clinic, or dozing off, just ask about both, I would say. Because again, they're both so interrelated that, you don't want to miss either.
And I would say I have one more thought. I was just thinking of a little guy who I really adore in our clinic who it is very apparent to our team that there may be some ADHD symptoms present. I think that there's also a role for us bringing that to parents' attention instead of just, shaking it off and not bringing it up if they don't bring it up, saying, hey, how is so-and-so doing in other settings? Like I noticed I'm thinking of this little guy, he runs around the hall, he runs out of the room, runs to the hallway, goes to the workroom, says hi to everybody, very sweet. And, takes things off the walls, brings it to the room. It's very apparent that these behaviors are different than most kids in clinic. And so I think it's fair to ask families, like, does this happen in other settings? Because sometimes, the mom would, feel kind of embarrassed, be like, oh, I'm so sorry, he's coming to bother you all. And we're like, well, we actually really love him, so it's adorable. But, starting that conversation and saying, like, is this something that's getting in the way at home? Like, I noticed you're feeling, you don't have to apologize to us, but like, how is this impacting your family at all? And I think we can really play a role in that way too, because parents may not volunteer necessarily that these things are going on, or even have that awareness that this is something they should be considering in their own differential.
So I think we've hit our time, but I am happy to invite anybody who has further questions that didn't get answered today to come up and speak to our panel. Look us up on the
TikTok?
I'm not on TikTok. To look us up on the NACFC app and contact us personally. We're happy to answer questions and follow up with anybody. So thank you.